Well, welcome everyone. This is the University of Utah Center for Global Surgery year-end showcase. Appreciate all of you in attendance and appreciate the speakers who are going to give talks today. I'm Brad Rockwell. I'm standing in as the interim director of the Center for Global Surgery. The department is in the middle of a search to find a new permanent director. I have a background in Ghana, and I'm going to give a little presentation on that. I'm now in my 14th year. My apologies for not being there in person, but on the day of the showcase, I'll actually be in Ghana, so I'm recording this in advance. So as I said, I'm a plastic surgeon. This will be my 14th annual trip to Komfo Anokye Teaching Hospital, which is in Kumasi, Ghana. So for the people that are not too familiar with Ghana, it's in West Africa, in that turquoise colored area. If you can see my mouse, it's on the southern central portion of West Africa. It's surrounded by French-speaking countries, but English is the national language in Ghana, so it makes it easier for us to work with them. In West Africa, Ghana, and Nigeria, the most medically advanced, and I think probably the most financially well off. And Ghana has a number of affiliations with the University of Utah and with other universities. So as you can see on the right side of the map, Kumasi, which is where I visit, if you can see my mouse is there. We fly from Utah, fly to JFK in New York, and then there's a direct flight, JFK to Accra in the capital, and a short 45-minute in-country flight. The University of Utah also has a general surgery affiliation in Cape Coast, which is in the central portion of their southern border. Most of the population lives in the southern half of Ghana. So I said 2012 was my first visit. At that time, there were 4 plastic surgeons at Komfo Anokye Teaching Hospital. It's the second biggest hospital in Ghana. There's also a medical school and residency programs. Of the 4 trained plastic surgeons who are there, they're all trained outside of Ghana. And there was the beginning of a plastic surgery training program in Accra and another one at Komfo Anokye. That first visit in 2012, they had their first plastic surgery resident in training. And that photograph on the right, he's the one on my right with a blue coat and white shirt and bow tie. That's Paco Hoyt Williams. He was a resident at the time. He's now the chief of plastic surgery. On his right, sitting down, is Pius Egbenerku, who was the first plastic surgeon at Komfo Anokye. And he was the chief of plastic surgery for a long time. Behind him is one of the residents at the time. And then over on your right is Joseph Akpolu, who's one of the other senior plastic surgeons. And then we fast forward from 2012 to 2025. They now have 6 plastic surgeons on staff. They've graduated 8 plastic surgery residents, have another 4 in training. We've had a hand fellowship formed at that hospital, which I'll describe a little later. And their faculty are really international plastic surgery educators and leaders, and I think it's the best plastic surgery training program in West Africa. Within West Africa, there are only plastic surgery residencies in Nigeria, Ghana, and Senegal. The other countries do not have training programs in plastic surgery, and some of the smaller ones don't have any surgery residencies of any kind. So when we started, question for me and the people that traveled with me, how do we set up an educational exchange? I thought it would be pretty simple. What works for us at the University of Utah in the United States should work for you. We We started there 2012, 2013, 2014. My connection was a anesthesiologist also from the University of Utah who had been visiting that hospital for over 10 years. And he gave me the introduction to Dr. Egbenerku. And mostly we did trauma, hand surgery, difficult, unusual cases, some cases that other surgeons there may have been hesitant to operate on. We chose what lecture topics would be. We would give lectures, and the lecture hall was usually pretty quiet. This was one of the cases we did in the second year. You can see the large tumor under his right axilla. It extends around to his back. It was an interesting case for us to do, but there's not a lot of teaching that goes involved there, with that case. This is another woman with neurofibromatosis of her face. Again, an interesting case for us, but they're just unusual. They may not see another one like this, and not as much teaching benefit as more common cases. So the third year, we went there, the sort of version 2.0 of our teaching. We would ask them, what would you like to work on? What can we help you with? Their answer was free flaps, which is a somewhat involved and technically exquisite operation that requires a microscope and micro instruments. They did not have those items, but we settled on muscle flaps, which is a much more versatile and more common case. And we did some cadaver studies. They found cases we did in the OR. That was really a good experience. For the lectures, we would then ask them, what would you like us to lecture on? They would give us topics. We would assess their needs. They would assess our capabilities. And then we said, what would work for you? And found a system that was really good. But a very important lesson was our teaching system did not directly transfer to their system. There are cultural differences, equipment differences in the operating room. Some of their patients find it very difficult to get to the hospital, and because of that, they may not come back for post-op visits. So learning their system and then adjusting operations to that system was a big learning point for me. Around the fourth or fifth year, Dr. Bafor Awuwa, we crossed paths with him in the airport in Accra, just serendipitously. I was with Dr. Egbenerku, and he actually asked if the plastic surgeons could start a breast reconstruction program. Dr. Awuwa was the head of medical oncology, and he was having a difficult time convincing women to undergo a mastectomy for breast cancer because the women did not want to lose their breast. It had been nourishment for their newborn children. It was part of their femininity. And a number of women were hesitant to have a mastectomy with reasonable understanding of what can happen if breast cancer is allowed to progress. So we went through a 2-year project, having discussions between the plastic surgeons here and there. We had some lectures on breast anatomy, breast reconstruction options. We evaluated what would be technically possible in their hospital and eventually came up with a plan using a tram flap. It's a flap from the lower abdomen. The blood supply comes from the rectus abdominis muscle. When I was a resident, it was state-of-the-art breast reconstruction. Now, free flaps and microsurgery have replaced it. And actually, a number of our residents have never seen a pedicle tram flap. But it does not require an operating microscope. It's a one-stage operation. You don't need a tissue expander. You don't need a breast implant. It's all natural tissue. And this was the first patient. There's the flap on her chest. She subsequently had another operation to do a mastopexy or breast lift on the right to help create symmetry. And at the same time, we did some fat grafting on the left. to make that side a little bit bigger. The patient was very pleased, and now breast reconstruction is a routine part of their surgical offerings. Residents who have trained in the program are now doing them at other hospitals in Ghana, and it's really a success story. Then we had another opportunity in 2019. I was sitting at our oral board examination in Phoenix, the plastic surgery oral boards. There was another person at the breakfast table, separate conversation for me, but he ran overseas projects for the American Society for Surgery of the Hand. They had started a hand fellowship in India and wanted to start one in Africa, but needed a location. And I overheard his conversation, politely asked if I could get involved in the conversation. I said, I have a location that I think would be great for a hand fellowship. And if you give the resources of the American Society for Surgery of the Hand with a location in Ghana, I think we can set up that hand fellowship. So in 2009, we started discussing it. It took 2 years to get it through, but in 2021, the hand fellowship was established under the auspices of the American Society for Surgery of the Hand and the Center for Global Surgery at Utah. It was the first hand fellowship in West Africa, maybe in all of Africa. It was actually the first postgraduate fellowship of any kind in Ghana. And it set a stage for several other fellowships that have now been formed. The Ghana College of Physicians and Surgeons certified this fellowship, realized that postgraduate fellowships were good for the country. And there are now several other surgical fellowships that have followed the hand fellowship that we started. 3 fellows have now graduated. One is in Kumasi, 2 are in Accra. And they're doing really good upper level hand surgery that previously was not available in Ghana. With the success of the hand fellowship, we then in 2023 put in proposals to have a breast reconstruction fellowship. To have a reconstruction fellowship, we really need to have a breast cancer extirpation surgery fellowship. And we put in a proposal for a burn fellowship, and those are still under consideration. None of them have actually started, but we're optimistic that within the next year or 2 they will start. We have the facility and faculty ready to go. We just need approval from the Ghana College of Physicians and Surgeons. This is the hand operating room at Komfo Anokye Teaching Hospital in Kumasi. The American Society for Surgery of the Hand overseas volunteer program is Dr. Don Lalonde. He's Canadian. He first described a technique using local anesthetic for hand surgery, not using an axillary block. The surgeon can give local anesthetic just subcutaneously, usually beginning mid-forearm, distal forearm, and you can get complete anesthesia of the hand. Epinephrine is included in the local anesthetic, and if the epinephrine is allowed to sit for about 20 minutes, it provides satisfactory decreased blood flow, so a tourniquet is not needed. The patient is wide awake. The patient walks in, walks out. It's called WALANT, W-A-L-A-N-T, for wide awake, local anesthetic, no tourniquet. And Dr. Lalonde brought several sets of instruments. He's visited Kumasi twice. And this is the room where they do hand surgery. It's an additional room. The operating room is right next door. The burn unit is right outside the room you're looking at. And when they do a case, a nurse from the burn unit will circulate. There's no scrub nurse. So the surgeon, usually with a resident, are scrubbed in. They don't wear full operating room gowns. They just use sterile gloves, so the cost is decreased. And this facility is available to the plastic surgeons and ortho hand surgeons 24 hours a day. Several other services have now used this. Urology was doing local procedures in here. This was the first local anesthetic room that the hospital had, and now there are two others set up by other surgical facilities based on the success of this room. So our exchange, we started with muscle flaps. Several there are listed. We then went on to breast reconstruction, hand fellowship with the, hand surgery with the hand fellowship that I described. And so recently we've been doing cosmetic surgery. That may seem like a unusual topic for Africa, but it has a very good benefit in that the plastic surgeons are able to earn some extra money by doing cosmetic surgery, and it has helped keep several of their plastic surgeons in country rather than having them leave the country to go to other areas, potentially outside Africa, where they might be able to earn more money. The local anesthetic operating room has allowed capacity to build. Last year, 500 operations were done in that local anesthetic hand surgery operating room. So that's 500 additional surgeries that were done in addition to the ones they had always been doing in the main operating room. The plastic surgery residency has expanded. And they're now finishing about one resident a year. So far, all of the residents they have trained have remained in Ghana. Several are at that teaching hospital, but most of them have gone to other hospitals where there previously was no plastic surgery care available. And the big lesson, what does not work, number one by far is people that you work with. I've been very fortunate that the plastic surgeons at Confo Noce have been very active to work with us. Several of their attendings have visited Salt Lake City. Usually each year, one or two of their medical students come and rotate on plastic surgery. They visit the University of Utah for a month, but several of them request to spend a week or two on plastic surgery. I think 5 of our University of Utah faculty have visited Confo Noce, and it's a very good international exchange program for plastic surgery. In addition to the people, it was really asking them what they need to try to be realistic. We're now trying free flaps, but I think 10 years ago, free flap was not a great idea to try on a clinical basis. But now we have a good technical basis. Technically, they're excellent surgeons, and we're progressing. As I said, when you see this, I will be in Ghana. We're going to concentrate on hand surgery this year. So that'll be great. The resident going with me is finishing her residency in June and will be a hand fellow at the University of Virginia beginning in July. And then what can we offer to them? It's definitely a bilateral exchange. We learn from them, they learn from us. Involves attendings, residents, and medical students, and it's a great process. This is a poster they put up on their door. This is, I'm actually standing in the residence room, and that's a poster on the board, but I think a good take on plastic surgery. Okay, so again, thank you all for attending the showcase. I apologize for not being there in person and presenting this real time, but I hope to log in, and this recording will be available for the showcase. So thank you all, and we look forward to other talks. Thank you.
Okay, so my name is Liz Elvira. I am the program coordinator for Center for Global Surgery, and as you just heard, Dr. Rockwell couldn't be with us, and due to unstable internet connection in Ghana right now, I'll just be doing a little bit of an intro to our next guest. So thank you, Dr. Rockwell, if you can hear me, not only for your presentation today, but also for stepping in as our interim director upon the departure of Dr. Jayraman. Next, we'll shift our focus to Ethiopia, where Dr. Tomas Tesfasilassie, and hopefully after a year, I've learned to say that almost correctly. Um, he is actually working to strengthen surgical and pre-hospital systems in Hawassa. His fellowship highlights the power of locally driven solutions to improve trauma care and surgical education. Okay.
Thank you very much. That was amazing. Great pronunciation. All right, let me share my screen. All right. So, like Liz said, my name is Tomas Tesfasilassie. I'm a PGY4 at Columbia University, and I'm this year's ACS Academic Global Surgery Fellow at the University of Utah. And my main objective was to focus on pre-hospital systems in Hawassa and also strengthening the surgical care. So I had two main projects, the first of which was the laparoscopic surgical curriculum at Hawassa University, which I spent most of my time on, and the other was to evaluate and improve the pre-hospital trauma system in Hawassa. So in regards to the to laparoscopic surgery in Hawassa University, we kind of noticed four issues. One of which was there was no laparoscopic curriculum at Hawassa. There was no structured training program. There was no laparoscopic skills assessment tools, and there was no orientation for the incoming interns in regards to laparoscopic surgery. So to tackle the lack of laparoscopic curriculum, what we did in conjunction with Hawassa University was to create a basic and advanced laparoscopic surgical skills manual. And in this manual, we discuss basic things like what is laparoscopic surgery and the tools that we use, and also discuss advanced skills like intracorporeal and extracorporeal knot tying. And what our hope is this will get approved by the university first, and then the Ministry of Health, so that it can be distributed to other residency programs for them to have a baseline for how they should set up their training manuals and give information to their residents. In regards to structured training programs, what we did was we created a Telegram group of 17 dedicated residents who wanted to learn laparoscopic surgery and were dedicated to the skills sessions. And in the 3 months that I spent in Hawassa, we did biweekly skills sessions where we learned the peg transfer, circle cut, intra and extracorporeal knot tying. And along with teaching the residents, what we learned is we really need faculty at Hawassa University that are going to be championing laparoscopic skills and laparoscopic surgery for the residents. And so we identified three faculty, one of which has laparoscopic surgery training in India, and the other two that don't, but are very enthusiastic about them. And so in the 3 months that I was there, I trained all three of them in all of the FLS tasks, which includes the peg transfer, circle cut, intra, and extracorporeal knot tying. And what we also did was they taught me these skills. So kind of in a teach one, see one, learn one. They kind of saw me teaching the residents, then they taught me, and then they taught themselves. So we kind of forced them to have 3 levels of training in terms of these skills so that they can teach the residents moving forward and not depend so much on the fellow that comes sporadically throughout the year. And without me even prompting them, they've actually started their own skill sessions, which I can track through the Telegram group chat that I added them to. So these on the left side, you can see the three attendings that I'm speaking about. On this day, we were learning intracorporeal knot tying, and of course, the electricity went out halfway through, and so we had to get creative, and we were using a flashlight and doing it outside of the skills box. In the middle, you can see me teaching 6 of the general surgery residents one of the skills lab, which is a peg transfer, and on the right side, you can see them training on their own. To tackle the last 2 issues in regards to lack of assessment tools and a lack of orientation for the incoming interns, we were searching the web and PubMed to see if there's any studies that kind of look at these issues, not only in low and middle income countries, but anywhere. And really, there aren't a lot of studies out there that look at the FLS portions in low and middle income countries. So we decided that this deserved its own study, and so we created a study called Evaluation of Laparoscopic Skills Among Incoming General Surgery Residents in Low and Middle Income Countries, a mixed method approach using laparoscopic skills, assessment tools, and self-assessment questionnaire. And the primary purpose of this is to assess the laparoscopic skills of incoming general surgery residents prior to orientation and then after a short training period during orientation. And the second objective was to see residents' perceived confidence and challenges in laparoscopic surgery, specifically in low and middle income countries. So in regards to the methods, what we're going to do is before orientation, we're going to do a skills assessment using OSAT's evaluation tool and another additional evaluation tool that we created for this study, and also have them complete a self-assessment questionnaire, which again we created for this study. And then we're going to have a 2-day orientation where it's going to be a combination of hands-on in the skills lab and also lectures. And then after orientation, it will repeat the evaluations and self-assessment questionnaire. So the OSATs, it stands for Objective Structured Assessment of Technical Skills. This is a well-known skills assessment tool, which is used for intracorporeal knot tying. There's 2 components, one of which is a specific component, which you can see on the left, and it is more of a binary scoring system where it's a 1 or a no, representing yes or no, and it's highly objective, and it includes things like where you load the needle, how you're doing the suturing, and how you're doing the knot tying. And it gives an opportunity for the grader to have a very simple, objective way to grade the trainee. And the other component is a global component, which is a score out of 1 to 5. And this gives a little bit more leeway for the grader to have a subjective input into the assessment of the resident. And this captures nuances like motion fluidity and adds context beyond just a checklist. This is one of the evaluation tools that we created for this study. This is a novel laparoscopic skills assessment tool. This one that you're looking at right now is for the peg transfer, but we also created one for the circle cut. And the reason we had to create these again is because there's no widely used assessment tool for these skills that is being used in research. And we actually found no research in these topics when we were doing our pre-study review. And within this study guide, this scoring guide, you can see there's a component of time, there's a component of objects dropped, which is a key thing for this for the peg transfer. And then there's more nuanced things like hand coordination, instrument handling, and error recovery. And the grading is 1 through 5. So when I was there and I was teaching the 3 faculty members who are going to be the graders during this study, the different skill sessions, I actually became the resident that they would be grading, and they graded me using these rubrics. And then we talked about kind of the nuances between what a 3 and a 4 might be, or a 2 and a 3, in some of these things that use open-ended language like mostly smooth or predominantly smooth or limited fluidity. And that gave us an opportunity to answer some of their questions and also give them an opportunity to see what a good or a bad or an average laparoscopic skills testee or a resident would be. And they really appreciated that. And the key of that is they're the ones that are going to be doing these studies, and we really want to empower the faculty members at Hawasai University to kind of champion this study and move it forward rather than having the ACS fellow come in and do the study and then leave and never be heard of. We really wanted to have their input and their agreement in this rubric. And the way that we created this rubric was in combination with some ACS faculty and also the Hawasai University attendings that will be involved in these studies. The self-assessment questionnaire, again, we created this on our own with the help of HAFSA at the University of Utah. And this is to capture residents' perceptions, confidence, and barriers in laparoscopic surgery. It has a few components that includes a self-rated confidence in tasks, perceived challenges, and also an open-ended portion. And the significance of this is to push the envelope of learning from just the skill session, but to also the perceived learner-centered insights so that we can improve laparoscopic surgery not only in terms of skills, but also the perception and the confidence for the residents that are undergoing these assessments. So looking ahead, we submitted the IRB for the study. I'm not sure if a lot of people are aware, but there's currently a big protest happening with the medical staff in Ethiopia. So the orientation has been delayed slightly because of that, but we're finalizing when the orientation date is. Again, we've already trained the 3 Hawasai faculty on the evaluation tools and also how the orientation is gonna go. And once we have the orientation date, we'll have more in-depth discussions about what lectures to actually use. And in order to decrease the burden on these 3 faculty, what I did was I actually recorded instructional videos on the 3 tasks that we're grading with voiceover so that they can have a very clear and concise way to teach the residents without having the pressure of remembering everything that I taught them. The other project is evaluation of the pre-hospital trauma care system in Hawasai, and I'll be very brief about this. The reason that this is important is because Hawasai doesn't have a properly functioning pre-hospital system. And as we know, trauma is the leading cause of death and disability worldwide, with 90% of the death happening in places with underdeveloped emergency systems. And we know that effective pre-hospital care could prevent 54% of deaths. So the study is called the Optimize study. It's optimizing pre-hospital trauma interventions and medical emergency systems in Ethiopia. And it's a comprehensive evaluation of the pre-hospital trauma care system in Hawassa, which I was involved in. And hopefully in the later years, a scale up to Addis Ababa using a mixed method approach. So what I specifically did in my time was I conducted 17 in-depth interviews with EMS stakeholders in Hawassa that range from dispatchers, policymakers, EMS staff, and hospital administrators. And we did this to identify kind of barriers that they saw in the EMS system. And we identified 6 key barriers that included infrastructure, resources, communication, community perception, workforce, system structure. And the importance of this portion of the study is, one, I believe and we believe that in order to solve a problem, you actually have to know what the problem is. And us being from the West or in America, we might have an idea of what is important in the EMS system or how to improve it, but that might not be relevant to the local needs and also be improved by the local resources. So we really thought this was a very important aspect of the study in order to make sure we create effective change that can be sustainable, even if we don't have funding in the years to come. And fortunately, this portion of the study was accepted for the ACS conference, and I'll be doing a quick short presentation during the October Clinical Congress. So I want to thank all of my mentors that helped me, the University of Utah. This has been a great experience in global surgery and kind of opening my eyes to all the good that we can do with limited resources. So I really appreciate the entire team and everybody that has helped me in my journey this year. Thank you very much.
Thank you so much, Tomas, for not only joining our team this year, but furthering our impact in Ethiopia throughout your work. Now we'll turn over to Rwanda, where our incredible scholar and medical student Michael Oravic has been instrumental in advancing both emergency response systems and vascular surgery training. His presentation on Rwanda 918 and the Vascular Care Initiative demonstrates how innovation can address critical gaps in surgical capacity.
Hi, everyone. Liz, thanks for having me. So my name is Michael Orvik. I'm a second year, about to be third year medical student at the Geisinger Commonwealth School of Medicine in Scranton, Pennsylvania. And I'm a University of Utah Global Surgical Scholar. And as Liz mentioned, I was lucky to be part of two projects, both happening in Rwanda, Rwanda 912, and then also kind of kick off get the ball rolling a little bit on the vascular care in Kigali, Rwanda. Yeah, so kind of actually as Tomas started to mention a little bit on his second project, trauma care, trauma injuries are the global leading cause of death in people under 46, and low and middle income countries are disproportionately affected. Uh, Everyone kind of knows about the golden hour following traumatic injuries with getting the patient to a hospital or to healthcare. You're really going to start to see that better mortality after that first hour. But unfortunately, a lot of lower middle income countries struggle to achieve the golden hour due to so many reasons. But in Rwanda, especially, they have a SEMU, which is their EMS service. It was established in 2007. They have ambulances, trained medical staff, and a very, very great dispatch team that I was very fortunate to work with. So Rwanda 912, it's a mobile health platform focused on improving pre-hospital care. I started in 2024, so actually around 1 year ago now. And I came in kind of at the end of the first phase of the project. And I know a lot of work was done prior to this, but really its focus at the time is locating patients more effectively and efficiently, as well as facilitating communication, not only between the patient and the dispatch team, but also between the hospital systems as well. It's a collaboration with Rwanda, the SAMU team, Rwanda Build, which is a tech company that is located in Rwanda. They've been instrumental and they built the entire software from ground up essentially for the app. So that's great, keeping it in the country. I really like this diagram of what Rwanda 912 is really trying to do. On the left is the current system or changing system where, the accident happens, a call is made to the dispatch team, and then there's a lot of stuff that happens in between the patient having an injury and then finally reaching the hospital. And that takes time. What Rwanda 912 is trying to do through the integrated platform is trying to make communication more efficient. So from the second that patient or a bystander makes the emergency call, there are guidelines and there's a set standard in place that will allow efficient hospital transport. So as I kind of mentioned, I came in on the back end of the first phase. So the first phase was baseline data collection using the two data sources. So the SAMU paper tracking, which is historically what they've used with their with their paper ID numbers for each incident, as well as just recording, the patient's name, as well as their injury, and just like dispatch site and dispatch location, as well as where they ended up. But with the Rwanda build data or the Rwanda 912 data, this is all electronically captured into an electronic database. So making it more efficient and just more collective together. And it took place over a year, from July 2022, November 23. And different data was collected, like the event district, delays in transit, as well as the severity of injuries. So what we were looking at was a primary outcome. What we really cared about most was the time from ambulance deployment to handoff at the hospital. Many secondary outcomes were included, and each one was a different portion of time, whether it was from the time on scene or the time it took from the ambulance from once they left the scene to reach the hospital, as well as handoff time. And we were mainly Rwanda 912 had primary focus was trauma, but all this other data was collected too for certain incidents, whether it was a pediatric incident or a neonate incident. So that led us to a few different things. But for the sake of time here, I'll just focus on some of the highlights from trauma results. On the left here, we kind of have this bell curve. So currently SAMU, their average time is around 54 minutes, and this graph does exclude some outliers, but that is kind of on the higher end of that golden hour, and we'd like to decrease that as much as possible. And then on the right, and this is average time of outcomes by severity. So on the all the way to the right is the primary outcome, which the red is the least severe, and then the gray is the most severe. And what we're seeing is minor, the less severe the injury, the quicker the primary outcome is. And when we like kind of break that down, we're seeing a lot of the time is spent on scene, or I should say more time spent on scene, the greater the severity of the injury. So right now, we're Rwanda 912, they're in the process of completing the implementation of the software package. And this is going to include routing to the patient as well as geolocation based on calls and direct in-app hospital communication. On my end, and I think on a lot of people in University of Utah, we have 2 manuscripts coming, and the one is so close to done, and the other is just, like so close to having the first draft done. So I'm really excited to get those out there. And then in the next phase, as I kind of alluded to, the field division hospital support, as we're seeing the more severe incidents are taking longer time. And this whole idea of the load and go versus a stay and play. So hopefully we'll be able to look at that and decide what is best for Rwanda, what is best for SAMU, what is going to be best to increase or to have better patient outcomes. So that's something we're excited for. So then vascular care in Kigali, yeah, this was kind of an exciting one. I was on the plane to Rwanda, or I should say in the airport, and then Dr. Jayaraman emailed me and she was like, hey, can you get this done? I was like, sure. No idea what it was. She just said something about vascular care. So this kind of was fun because I had like no preparation at all going prior to my, I think it was a 30-hour travel day. But so I worked with the team, the Dr. Foston and his team of plastic surgeons over there to figure out what we needed to do first. So as far as vascular care in just in low middle income countries in general, so a lot of global collaboration historically has been focused on communicable diseases, whether that's malaria and HIV, and they have seen great success. The average life expectancy is increasing, but with that, we're also seeing an increase in non-communicable diseases like cardiovascular disease. Cancer is another big one. But what we're seeing kind of is a stagnation of surgical care compared to other healthcare sectors. But we're also seeing increased surgical conditions. And vascular care are the most frequent cause, cardiovascular conditions are the most frequent cause of non-communicable death in sub-Saharan Africa, accounting for 37% of non-communicable death and 13% of all deaths. That was from the one paper, Global Surgery 2030, from the Lancet. So in Rwanda, what we're seeing is 44% of deaths in 2020 were due to non-communicable diseases. And currently at the time, they have no fellowship-trained vascular surgeons that are based in Rwanda. They have a few people, from what I understand, that come in to visit and do operations, but no set surgeons. And so care is provided by the visiting vascular surgeons, and really they don't know the prevalence or really incidence of vascular conditions at all. A lot of the times, if a surgeon notices it, they could recognize it, like let's say varicose veins, for example, but they don't even document it because there's really nothing to be done. So what we're working to do through our collaboration, University of Utah and the teaching hospital of Kigali, is develop a vascular surgical fellowship. And this will improve patient care, increase vascular surgical presence, not only in Rwanda, but hopefully in the entirety of East Africa, and then benefit the economy too. So when I talked to Dr. Foston, we came up with the idea of a survey. And we were like, okay, so I was there for, I think, 4 weeks total. And so we had to kind of get this done in a very fast manner. And talking to him and talking about the best way to reach surgeons in Rwanda and really just get the idea, he's like, it's going to have to be an online Google survey that everyone could access, and it has to be very straightforward. I was like, okay. So that's what we did. And the survey was to explore the prevalence of vascular conditions and ask the surgical staff, what is their level of training in vascular surgery? What are the barriers to it? And like what needs to be done? So we distributed to the Rwandan Surgical Society, 169 members total. We got 22 responses, which in the 2-week timeline, we'll take that. And they represented 4 surgical specialties. It was orthopedic, general, urology, and then obstetrics. They were the 4 that were represented. And every single surgeon indicated a high interest and need for vascular surgery in Rwanda. So when we asked them the common conditions, we asked them to list their top 3. Varicose veins, without a doubt, were the top at 64%, as well as just peripheral artery disease and aneurysms. But interestingly, trauma. So trauma is a big one because a lot of the times where trauma in, like, let's just say in America, for example, an injury happens, okay, we could solve that through vascular surgical conditions or, whatever. But a lot of times in Rwanda, it's leading to amputation. So it's a really severe burden on the hospital system and on the people of Rwanda. So as well as the classification, most of the conditions are elective conditions, which I do think is great, a good sign, but still urgent and emergent conditions are almost 20%. So there's definitely a need there. So these are the barriers to vascular care as indicated by the surgeon. On the left, almost every single surgeon actually indicated training in vascular care as a barrier, as well as human resources, hospital equipment, but then also vascular surgery specific consumables, with most hospitals having little to none based on the survey results. On the right here is the resources that the surgeons indicated that are available at their hospital. And again, over half said there are no vascular surgery specific consumables. Some indicated basic equipment, but really there's a need. So based on the survey results, and it's very common, we're looking to implement a vascular surgical fellowship training program at Shayashika, Chuck, and that's currently underway. Dr. Brook from University of Utah, last time I spoke to him, he went over there, and they're doing a lot of good things. I know China is currently building like a hospital that will be equipped for vascular surgery, so I don't know where we're at University of Utah and collaborating with all that, but it's definitely on the horizon. And as well as integrating vascular surgical training modules into existing surgical residency programs in Rwanda. That way, any surgeon that is in the residency at Rwanda will have at least some exposure and some skills in the vascular realm. Yeah, so I just wanted to end on my experience as a medical student. I was really thankful to be a part of the University of Utah, the global surgery team. It allowed me to get firsthand experience in the field of global health and global surgery, and as well as different perceptions. As Tomas said, you read about like sub-Saharan Africa, #1 cause of trauma is road traffic conditions, and it doesn't really hit you until you get there, and you can see like, yeah, this is a huge problem because everyone's on their motorbikes and they're not wearing helmets, and it's a lot of just going. There's very little traffic, organization, as well as the cultural impact. Got to interact with a totally different culture that was great. And then Dr. Foston, who was the head, kind of my key contact over there, he said something, as a medical student, you always try to pick up things from everyone you interact with. And after a resident gave I thought it was a fantastic presentation of someone with it was a degloving injury of their leg. And Dr. Foston just sat there and he goes, listen, we don't treat injuries, we treat patients, because the resident did talk pretty much all about the leg and really no information on the patient. But I was like, wow, like that was pretty profound, I thought. But I just want to give acknowledgments to everyone listed here, and there's so many more people, but a special thank you to Liz and Anna. I think you guys were 2 of the first people I got involved with early on. Dr. Foston, Jayaraman, and Brooke, and everyone else, Teresa and the rest of the University of Utah statistics team. Couldn't have done it without you, that's for sure. But yeah.
Thank you so much, Michael. Yeah, I had the pleasure of working with you throughout this year, and truly you have been one of the best medical students I have worked with in my short time here. That being said, you were a very integral part of our team, so thank you so much. Our final presentation is by graduating medical student India Burdon Dasbach. She is going to bring us back to Ghana, where she's examining the financial risk of surgery. Unfortunately, India could not be here with us today, but she has prepared a similar presentation as our keynote speaker, Dr. Rockwell. I'll just pull that up now.
Hi everyone, my name is India Burdon and I am a graduating fourth year student at the Geisel School of Medicine at Dartmouth. This year, I've been working as a global surgery research scholar with Dr. Nunez, and I'm excited to present our research titled Measuring the Financial Risk of Surgery in Ghana. I want to thank Dr. Nunez for his great mentorship throughout this research project, and I've learned so much about this topic and global surgery research as a whole. I also want to thank Liz and Anna who have helped me throughout this year and made all of this possible. As I'm sure most of you here are aware, in 2015, the Lancet Commission on Global Surgery was published, indicating that greater than 5 billion people globally don't have access to safe, affordable surgical care when they need it, with the highest unmet need being in sub-Saharan Africa and South Asia. As a part of this landmark paper in global surgery, the Lancet Commission put forth 6 indicators for the purpose of reporting and tracking by all countries and global health organizations for understanding and measuring the status of countries in terms of surgical access. This data is to be used to inform national planning, be able to appropriately compare across countries, and be able to track progress and change over time. 2 of the indicators consider financial risk of surgery. All of these indicators include 1. Access to timely essential surgery, which is access within 2 hours. 2. Specialist workforce density, or number of surgeons. 3. Surgical volume, or procedures done per year. 4. Perioperative mortality. And then 5 and 6 are the financial indicators. 5. Protection against impoverishing expenditure, defined as the proportion of households protected from impoverishment from direct out-of-pocket payments from surgical and anesthesia care. And 6, protection against catastrophic health expenditure, or the proportion of households protected against catastrophic health expenditure from direct out-of-pocket payments for surgical and anesthesia care. Because cost is a primary consideration for patients deciding whether to seek treatment in the first place, the risk of catastrophic health expenditure is a more telling indicator of access rather than just incidence. In terms of financial risk of surgery, another important paper by Schreim et al. In 2015 followed the Lancet Commission on Global Surgery to create a global estimate on the catastrophic expenditure for surgery worldwide. This paper was an important model or metric for how catastrophic health expenditure was thought about and considered around the world, and this model's calculations were some of the only available approximated measures for catastrophic health expenditure in many countries. World Bank data were used for each of the necessary parameters in 199 countries, and GDP per capita was used as a proxy if household data was not available. WHO choice estimates for the unit cost of a cesarean section were taken to represent the costs of surgery. Each country had an estimated catastrophic health expenditure based on this model. Unsurprisingly, the map for the risk of catastrophic health expenditure aligns with the lack of access to surgical care presented in the Lancet Commission. However, this modeling study has its flaws, in that it's a model and not real data, and the standard is using just the cost of a C-section, not other surgeries, to represent access to all of surgical care. Without collecting real data, this is what has been used in many countries to understand financial risk of surgery. After the Lancet Commission was published in 2015, and there was greater awareness and acceptance of surgery as a need in the global health space, an analysis by an international group of global surgery researchers in 2019 found that despite a positive reception of the importance of global surgery following the Lancet paper, none of the indicators were being collected routinely and reported to the WHO. Instead, academics, societies, and non-governmental organizations were compiling and providing data on surgical and anesthesia care. Because of this, a lack of standardization of the indicators was limiting their utility, and the data availability still remained low. The Udstein Perioperative Metrics Project was formed to address this problem. A group of global experts convened in July 2019, with discussions continuing through August 2020 to evaluate and explicitly define the indicators. The group also agreed upon data points needed for construction of each indicator at the current time, which is at the basic level, and as each evolves over 2 to 5 years at the intermediate level, and greater than 5 years at the full level. They removed one of the original 6 indicators, impoverishing expenditure, and refined definitions and descriptions of the data points required to construct the 5 remaining indicators: geospatial access, workforce, surgical volume, perioperative mortality, and financial risk protection, which is measured by catastrophic health expenditure. After the consensus report was published by the Utstein Perioperative Metrics Project, a research group led by surgeons Dr. Nunes from University of Utah and Dr. Giedu from Kwame Nkrumah University in Ghana sought to assess the collection of these newly defined indicators. This study assesses the feasibility of implementing the Utstein Perioperative Metrics Project methods in Ghana, a lower middle income country with advanced data infrastructure. Ghana was selected as a test site due to its demographics, economic conditions, and health information system infrastructure, which present a practical testing ground for the newly refined indicators. Data from the Ghana Health Service and Ghana Statistical Service were used to calculate 5 surgical indicators at the Utstein Perioperative Metrics basic level. For Indicator 5, financial risk protection data, a prospective patient exit survey was used. Per the Utstein guidelines, a prospective patient survey is the preferred method for collecting financial data, as it's the most accurate way to find out what people truly spend. They also recommended conducting a survey immediately upon discharge, which was done, in order to prevent any recall bias or alterations to the numbers reported. A nationally representative selection of the public, private, and missionary hospitals were interviewed. They were interviewed at the time of discharge and on follow-up via phone 1 month post-discharge, with also some additions made to the survey to collect this longitudinal data. Data was collected at the basic, intermediate, and full levels, and data was also collected beyond these levels related to patient spending. I have used the term catastrophic health expenditure as the method of measuring financial risk, but I wanted to break down the definition and show how catastrophic health expenditure is calculated. While there are several calculations considered to calculate financial risk, catastrophic health expenditure has been deemed the most appropriate and widespread way to measure risk. In calculating catastrophic health expenditure, 2 main methods have been used. The first is the budget share approach. This is when out-of-pocket payments exceed a defined proportion, which is typically 10%, of a household's total income or expenditure. The second is the capacity to pay approach. This is when out-of-pocket payments exceed a defined proportion, typically 40%, of a household's expenditure remaining after basic needs have been met. I wanted to bring this up in case anyone is looking at or aware of studies on financial risk of surgery in the US or other high-income countries, which often uses the more complicated capacity to pay approach in its calculation. There are pros and cons to both methods, but overall the budget share approach is easier to collect, requiring less data, and thus is more suited for lower middle income countries. The downside is that this approach does not consider variation in spending across income classes. For example, people with lower income classes will spend a greater proportion of their finances on basic needs compared to those in higher income classes. The capacity to pay approach accounts for the potential variation in spending across income classes. However, it requires more data and is harder to collect, so it's not used for lower middle income countries. In catastrophic health expenditure calculations for studies conducted in the US and other high-income countries, this approach is used since we have larger databases from national surveys, hospitals, and insurance companies that are easily accessible for data analysis. The Utstein Perioperative Metrics Project recommends the budget share approach, which is the definition we use in our study. As I mentioned, the global surgery world has come to a consensus to use the budget share approach, which is out-of-pocket costs over total household expenditure or income being greater than a certain threshold, which is most commonly accepted to be a 10% threshold. The data sources used to calculate catastrophic health expenditure are significant and can make a big difference in terms of accuracy of calculations. For out-of-pocket costs of surgery, many studies have used hospital billing records or national accounts to calculate catastrophic health expenditure, as this is easier to obtain, but often not as accurate of a representation of what patients are actually paying. It's also important to collect data at the time of the event to prevent any recall biases. For household expenditure or income, nationally representative surveys and patient surveys are the ideal way to collect this information directly from individuals. In considering out-of-pocket costs, There are lots of ways to include or not include the costs associated with surgical care, which has a big impact on the catastrophic health expenditure calculation. Direct medical costs are the costs of medical care provided, the medicine, surgery, or procedures, medical supplies being used. Direct non-medical costs are those associated with obtaining medical care, lodging and food during the hospital stay, transport to the hospital. Indirect costs are opportunity costs associated with obtaining medical care, such as the loss of earnings from missed work or loss of crops. In most studies, only direct medical costs are considered. Putting all of these definitions together, the Utstein indicator data levels for financial risk can be more fully understood. For basic level data, this is to be collected in 2 years and uses direct medical out-of-pocket costs expenditures from a C-section to approximate the catastrophic health expenditure for all of surgical care. At the intermediate level, this is to be collected in 2 to 5 years. The definition is expanded to include direct medical out-of-pocket cost expenditures for long bone fractures and laparotomy and pediatric surgeries in addition to cesarean section. For the full level, to be collected in greater than 5 years, that should be using all procedures in the Utstein procedure list and also includes direct non-medical costs, health insurance contributions, and geographic disaggregation. Through the prospective patient survey in Ghana, all 3 levels were collected. Notably, though indirect costs are not considered part of the Utstein financial risk protection indicators, they are still important costs which were collected in our patient survey, and we will plan to present that data in one of our papers. So first, data at the basic level. This includes direct medical out-of-pocket expenditures and household expenditure from a nationally representative survey related to cesarean section procedures. The median direct medical cost of a C-section was 910 Ghanaian cedi, and there's about 14 cedi to $1, making this approximately $61. To put this in context, the median annual household income across all of Ghana is approximately $730, though great variations exist. The incidence of a 10% catastrophic health expenditure at the basic level is 10.6%, and the national risk is 0.231. At the intermediate level, direct medical out-of-pocket expenditures and household expenditure from nationally representative surveys related to cesarean sections, long bone fractures, and exploratory laparotomy was used. Though pediatric surgeries are considered for the Utstein Perioperative Metrics Project, this was not collected in our study and is one limitation of our survey. As you can tell from this data, there's big discrepancies on the costs of different procedures, with laparotomy being more likely to induce catastrophic health expenditure than C-section, and open fracture posing a very high risk of catastrophic health expenditure compared to the other 2. At the full level, direct medical out-of-pocket expenditures and household expenditure from nationally representative surveys related to all of the interventions on the Utstein procedure list should be collected. However, this list has not yet been created, so for our study, we included the 3 surgeries of C-section, laparotomy, and fixation of open fracture. At this full level, data also includes direct non-medical costs, health insurance contributions, and geographic disaggregation. As you can see, as more types of costs are considered in the calculation of catastrophic health expenditure, the incidence and the risk increase for all types of procedures. Geographic disaggregation data was also collected. Geographic variations in risk of catastrophic health expenditure existed in our survey data, with the highest risk areas being in the more rural regions of the Upper West, Upper East, Northern, Brong, Ahafro, and Volta regions. In addition to the Utstein Perioperative Metrics Project's defined terms of measuring financial risk, there are additional calculations that can give even more in-depth information about financial access to surgery for our population. One of these is catastrophic total cost. Due to the recognition that non-medical and indirect costs, such as costs of travel and food during health seeking, and indirect costs of loss of income for tuberculosis, a medical condition that requires longitudinal treatment, the WHO developed a tuberculosis-specific financial indicator called catastrophic total cost. which incorporates both direct non-medical and indirect costs into this calculation. This idea has not yet been explored in surgical care, but the longitudinal aspect of some surgical patients, such as those with long bone fractures or abdominal catastrophe, suggests that they too would incur significant financial burden with longitudinal treatment. Impoverishing expenditure is another term defined as out-of-pocket spending related to medical care that pushes a household below the poverty line. And a final calculation to consider is the proportion of people below the poverty line who are pushed even further into poverty. So any spending for a household that's already below the poverty line. As you can see from our data, when considering indirect and longitudinal costs in the catastrophic total cost calculation, the financial risk increases across all three types of surgeries. With all of this data collected, we have several papers that are planned. The first is the feasibility study which collects the Utstein indicators in Ghana and discusses the feasibility of using these newly refined indicators. The second is a report of all 5 Utstein indicators in Ghana. The third is an expanded financial risk analysis, which will include different calculations beyond the Utstein recommendations, such as indirect costs and total catastrophic costs. And a fourth paper for future writing considers impoverishing expenditure paper or an editorial discussing people who are below the poverty line who are pushed further into poverty by seeking surgical care. Here are some of the references used in this presentation. And finally, thank you. If you have any questions, please feel free to email me. I've left my email on this slide. I'm sorry I was not able to be there in person, but I hope that the rest of the showcase goes well.
So I'll jump in. It was a real pleasure to work with India. She just did a very good job of summing up what can be a very wide-ranging and sometimes tedious topic. But she jumped in with both feet and is a really quick study. We are very lucky to have landed her as one of our incoming surgical interns. And so she would be a real catch for the surgical fellowship or for the global surgery fellowship in her time here. So I think she's climbing some mountain, so she'll fit right in here. I am certainly happy to answer any questions you guys may have on the presentation, and I can probably speak for everything that she just really expertly communicated.
Yeah, thank you to all the speakers. Thank you, Jade. I was wondering, how accurate do you think the data is that you're getting, and how complete?
Yeah, so as far as the financial risk component was the only prospective aspect of that study. And I mean, this is the point of doing it. It's patient bedside surveys. As she said, modeling was sort of what was tried first. That's great in a pinch, but there are probably too many assumptions to be terribly useful. There have been other studies done, especially in the US, with hospital billing data, and that's been shown to not be terribly accurate as to what the patient actually pays. As you can imagine, we don't have any records of what they actually end up paying. You can imagine in the States, we can bill someone for $1 million and they may pay nothing. But in Ghana, you can't leave the hospital until you know your bill and have paid it. And so as far as like direct in-hospital medical costs, very accurate. And then a 30-day follow-up was also wonderful because I got to find out how many days of work were missed. And so we could do a calculation on those indirect losses. We also asked them questions about their transportation. So those are non-medical direct costs. And so this is about as good as it gets because they were interviewed just before discharge in the hospital, and then just 30 days later. We've recently realized that we're coming up on a year, and we're making plans to call them back and get year-long costs to have true catastrophic total costs of things like major trauma and abdominal catastrophe. But I also would acknowledge that there's probably some recall bias around sort of emergent and acute settings. So I don't think there's probably a perfect way to collect this, but I think this is about as good as it gets.
Yeah, that's a great study. Thank you.
And before we let you all go for the night, we want to thank Dr. Nunez. As you all may know, he is leaving the University of Utah and Utah in general later this next month. So this is not only just a major loss to the trauma team within the surgery department, but also to us. You've been incredible and instrumental in so many of our projects. So thank you so much. We are sad to see you go, truly, but we wish you the best and we hope you come and visit or, just return fully someday. We're already thinking of that day, hopefully. But yeah, thank you all so much for attending tonight, and thank you to all of our presenters, and I'll let Dr. Rockwell close us out.
Yeah. Well, thank you, everyone. I'm now back where I'm staying, so I have a more stable internet connection. But thanks to everyone. Thank you to all the speakers. Thank you to all the people that listened. The Center for Global Surgery really appreciates your participation. The Center for Global Surgery lecture series will take a break now for several months, and then we'll resume again in the fall. But thanks again, everyone. Appreciate it, and have a great summer.